All right. So this will be the start of the second senior lecture today, following Rick Vick's amazing, not Rick Vick's, following Derek's amazing lecture. I apologize to Derek. Derek's not here right now, so I didn't hear that joke, so that never happened. Let's get started. So I want to talk about today medical errors, malpractice, defensive medicine, and kind of touch in about tort reform a little bit. These are some things we don't really get much about in residency. I think we get like usually one lecture a year about it. Last year we were lucky enough to have Beth's sister, and the year before Selby had like a bunch of lawyers come and talk to us about it. But most of the time they're from sort of their perspective and the sort of defensive litigation stuff. And I wanted to touch base a little bit more from our side of it, from what the physician sort of deals with and how to deal with it, how to avoid maybe some mitigation risk practices, and how to deal with the idea of maybe changing your practice if you get sued. The first thing really I want to do is talk about defensive medicine versus careful practice, because those are two different things. A lot of times we say, a physician is defensive when they're ordering too many CAT scans, but that's really not the real thing. Defensive medicine defines as you're making a decision based solely on avoiding a lawsuit. Whereas careful practice, you want to limit your uncertainty, right? So you're getting that CAT scan because you want your uncertainty to be zero. Whereas, we're lucky enough to be in a program where we have a diverse faculty who are acceptable of certain uncertainty, and some of them that don't want certain uncertainty. But I wouldn't say anybody in our program is really defensive. No one really thinks about like, hey, I'm going to order this so this patient does not sue me in the future. Maybe there's like one or two, but otherwise, for the most part, most of us can go either maybe more careful practice or not. There's not much studies on defensive medicine. A lot of these are surveys. They ask sort of doctors how their practice patterns are. There's no really way to go into a chart and see which orders are done for which reasons or not. Every doctor has his own experiences and their own sort of like motives and thought processes. And Derek said it best, especially when he talked about the Trump thing, is you kind of deal with the patient's sort of own preferences and help that, drive your decisions, and being sensitive to that. Doesn't necessarily make you defensive if you're going to give hydroxychloroquine to a patient who's afraid. I know there's no evidence based on it, but you take everything into account when you do the best sort of clinical judgment for the patient. And again, we're here for the patients. So just to say, like, there's no evidence based on anything to not do a CAT scan, or doing a CAT scan is defensive, it's not really the case. The biggest thing people become defensive is because of lawsuits, right? And initially, lawsuits have been going on for a while. Malpractice has been something that's written about since the times in England in the 1700s. Malpractice was sort of like the Latin definition of it. It was defined back then as neglect or unskillful management by a physician or servant. A couple of studies do show that 4-year EM residents, one of them was in California, showed that moderate malpractice concerns in defensive medicine, which did not really change over time throughout their 4-year sort of residencies, and didn't impact their decision in the future to perform anything. And a lot of times the lawsuits they were brought up against patients from errors of commission, making a mistake. Whereas now, because we're, the reason we're becoming more defensive, or some people might say, is because we're not doing enough. Initially, in the invention of x-rays, people were missing the fractures, missing the tumors, whereas now you're not getting the x-ray, you're not getting the CAT scan, and that's why you're being sued. And malpractice isn't necessarily, you're not going to get sued because of your medicine. A lot of it is going to be more of strategy. You could do everything right and can still be sued. And this, of course, risks your way of practicing the way you want to do it. There's a couple of papers that talk about the ethical considerations of defensive medicine and the argument against it. And when we talk about sort of medicine and ethics, we always talk about, those 4 things: maleficence, justice, do no harm, and autonomy. This author, Johann Bester, had written about why it's morally wrong to be defensive, right? The first spot, you're breaking the patient's autonomy, right? Clinicians are obligated to provide the full disclosure of necessary information to the patient when you're implementing a test or a procedure. a couple of attendants do this when they don't want to, when they want to order a CAT scan on somebody, they talk, to the person about the risks of the CAT scan, the risk of sort of incidental findings, the radiation, to allow the patient to be autonomous and make the best informed decisions for themselves. You shouldn't make a decision to order something to avoid getting sued. Because if that's your decision process, you should not order that test. The other thing is, we have a fiduciary, it's spelled wrong over there, but a fiduciary relationship with the patient. We want to do what's best for the patient, right? When in a business standpoint, if you're going to get an accountant or sort of a manager for your money, you want somebody that's a fiduciary, who's not going to do things based on what he wants to make the most money. He's going to do things based on what's best for you, and that's our job for the patients. And so we have to put the patient's interest as well above it. I can't tell you how many times I've ordered an ankle x-ray on somebody that was Ottawa ankle negative. I don't think I've ever used that before. But that patient wants an x-ray because they're afraid of an x-ray. And so I offer them the decision, like, hey, x-ray might be negative, but if you want the uncertainty of it to make sure it's negative, we'll get the x-ray. Defensive medicine also employs test or interventions with no hope of benefit. So you're putting patients into more risk. You're doing harm by getting the radiation that maybe they don't need. You're getting that CAT scan of the head on somebody that's, or C-spine on somebody that's like a nexus negative, that they don't need that additional radiation on their heads. And those are big, big factors. It also undermines the practice of medicine, right? There's a big, the patient-doctor relationship is based on trust. And so if patients believe that we're just doing this to not get sued, they become more distrustful of us. They're like, oh, why aren't we ordering this? Why are we ordering this? And that negatively affects the way we practice medicine. And then when it comes to sort of justice, right, it violates the obligation of justice. You're using money and resources and time for, tests and procedures that aren't necessarily effective or beneficial to the patient. So these are, the big ethical arguments against defensive medicine. And one of the ways we try to avoid it is to, think about what the patient wants best, what's best for the patient, not think about our own sort of selfish reasons for ordering stuff. A couple of ways to limit the thought process of being defensive was a big initiative first started by medicine. ABIM started this sort of campaign of choosing wisely. ACEP initially did not participate in this for a multitude of reasons. They actually opened up 3 different task forces to see whether they wanted to be involved in this campaign. And this campaign involved, they wanted every specialty to think about, 5 to 10 things, procedures or tests that are maybe unnecessary. And we should think, twice about before ordering for patients to avoid unnecessary spending. Because defensive medicine in certain accounts costs up to $50 billion in the US sort of healthcare budget of unnecessary tests. So initially ACEP said no, but eventually they went along with it. I think in around 2013, they came out with like sort of 10 things to do. One of them being, somebody under 50 years of age with known, stones, not to get a CAT scan for them if you're that, suspicion for a stone is high. Or, using guidelines like a nexus criteria or Canadian C-spine to avoid unnecessary testing on these individuals. Because defensive medicine accounts for about 2.8% of total healthcare expenses, which, the percentage is low, but the monetary value is still high. And so to switch shifts a little bit, we become defensive because, you're sued. And how many attendants here have been named in a case, right? Literally everyone's hands got up, every attendant here, and there's like, this room is packed. There's about 100 attendants here. And I'm sure at home, residents as well are getting named. I was named maybe a year ago with Dr. Quinn as well. So everybody's at risk. This will happen definitely in your career. I think 2 years ago when the lawyers from Selby's sort of conference came, they said the only way to not get named is to move to Aruba and not practice medicine for 2 years and let the statute of limitations on whatever last patient you had kind of go away. And that's the only way you will not be named in a case. And even then, you cross your fingers and pray and hopefully you won't be named. And most of the things we get named for, discharge a little bit much, but missed MI, those are usually the higher risk things we get named for. Missed MI, abdominal pain leading to appendicitis, intracranial bleedings, or pediatric fever, meningitis. More of the low risk things were found in sort of a couple of studies where missing foreign bodies on X-rays or missing fractures on X-rays. But still, these are high things we think about, we consider, we order the right tests, and hopefully we're not defensive about it. We're not just ordering troponins on a 20-year-old with some weird, costochondritis pain, but we're thinking about these things. There is a way, of course, to reduce your, malpractice risk. There's a couple studies that show we actually overestimate as physicians the likelihood of us getting sued. Only about 10% of malpractice claims actually go to trial, and most of those claims actually favor physicians around 80% of the time. But the way to reduce that, it's still a stressful time, even if you get sued regardless of the event. The way to reduce it, of course, is a couple of these sort of tools to use. Clear patient communication, right? Your discussion with the patient, you're talking about them, talking about the plans, talking about the risks. Documentation, right? If you don't write it down, it didn't happen. That accounts for everything. Reassessments, that's another big thing. If you didn't write down, you reassess the patient before discharge. If you didn't write down the new vitals, if you didn't write down, you talk to them about, leaving against medical advice, against return precautions, then it didn't happen. Utilization of clinical practice guidelines, that's helpful as well, right? It kind of helps you out a little bit. This is the best standard of care. And a lot of times, the best standard of care isn't the same in every hospital, right? Kings County and downstate have multiple consultants and our tertiary care centers and trauma one centers. Whereas if you go in the middle of, Minnesota or some random other states that, are far away from anything, the standard of care there is different. And so you have to be cognizant of what the standard of care is at your own place and understand sort of what the risks are. A couple of remedies, we'll jump to a little bit of the things that doctors in general say will help us against sort of like malpractice and kind of reduce the risks. And they always talk about like tort reforms. Safe harbor and clinical practice guideline rules are kind of both the same. It means that if a physician uses the best evidence based for something, that they're protected from a lawsuit, right? If I use the hard score to discharge somebody, I'm protected from a lawsuit. If I, if I don't scan somebody's neck because of nexus criteria, that's evidence-based that I'm protected from a lawsuit. Those are certain things that we kind of push for and want it in our reform of, the judiciary system when we do it. Comparative fault reform is another aspect where the percentage of blame is sort of discussed. Was this all the physician's fault, or was this sort of partly, the patient's fault? The patient did not follow up as sort of, recommended, or patient didn't do this as recommended. And that takes, a percentage of how much fault the physician had to, break up whatever monetary value they might get in that. Plaintiff attorney fees are also high. That'll also reduce sort of the amount of money you have to spend on malpractice. These things are potential remedies. And apology laws, meaning you can apologize to the patient for any sort of mistake or error without being held at fault. None of these actually rules are actually rules in effect anywhere right now in the US. A couple of recent studies even showed that evidence-based guidelines would only be applicable to a minority of cases. So even if you use that, it doesn't really affect much of the malpractice claims. And to put these into effect would mean we have to police ourselves, and it's always difficult to police yourself. A couple of states that had laws, Texas, Georgia, and South Carolina, did enact a lot of, or pretty broad malpractice tort reforms. And there's more than just 3 states that are, several states do it. New York does not have it, I believe, but several states have similar laws. One of the biggest things that these 3 states did was to make it that there is willful negligence. You have to be grossly incompetent. You have to prove without a doubt that the physician purposely wanted to hurt somebody, which is hard to do. I don't think anybody in their mind goes in to see a patient and say, hey, I'm not gonna order this, even though I know this is gonna help, just to harm the patient. So these are supposed to be less stressors in our life and make us less worried about things. They also put caps on non-economic damages. Instead of being sued for $10 million, there's a cap on $250,000. But these laws also showed that maybe they don't really work. The 2003 Texas reforms in one study showed that there was a 60% overall reduction in malpractice claims and a 70% reduction in malpractice payments. But several studies don't really show that this changed physician intensity and changed physician practice. In the 5 states with the highest malpractice risk, 68 of physicians reported that they engaged in defensive medicine. They ordered the test that was not necessarily just to do it so they don't get sued. And in the states with the 5 lowest malpractice risks, only 64% said that. It's only a change of 4% in pretty broad states. It does show that non-economic damages were associated with a decrease in defensive medicine, but the overall healthcare spending did not really decrease. One of the reasons tort reform and all these things don't really get talked about much is because the Congressional Budget Office analyzed sort of the percentage of healthcare expense and saw that tort reform would only fix 0.3%. And so if something's only going to benefit, the overall healthcare spending of 0.3%, maybe it's not really that worth it. There's other kinds of non-traditional approaches that have been discussed and talked about. Some of them are judge-directed negotiations to kind of avoid lawyers. Some of them are just healthcare systems and, to arbitrate directly with patients for any sort of errors. But those things are also not entirely in effect yet. In our time of loving FOMED, there's a really good podcast called Doctors and Litigations. Again, this is a topic that we don't discuss much about, and I found this podcast super helpful. It is by an ER physician. Her name is Dr. Geeta Pensa. She contributes to MRAP, so Robbie loves that. But she talks about sort of, the stressors of lawsuits, the ideas of expert witnesses, and what she calls testaliers, which are expert witnesses that are just go on a stand to help, to push a certain sort of narrative. She talked about a story where one of her cases, she had a neurologist or a neurosurgeon talk about one of her cases that she missed a vertebral artery dissection. And she won the lawsuit, and it has been going on for 10 years, and she got re-sued, and they kind of changed their strategy the second time, saying that she never gave aspirin for this, even though the patient was dysphasic, and they had an expert witness saying the neurologist in general, the residents, carry aspirin in their pockets and give aspirin to patients. So if she would have given the aspirin, this patient would have not stroked out. There are ways to protect yourself from expert witnesses. If you are getting named, you don't do it then, you do it after the trial. ACEP does have guidelines for expert witnesses. You have to be 3 years out of residency, you have to be practicing in the US, you have to be in good standing, and you want to have a license in whatever state and specialty that you actually do. But there are ways to bring it up if you feel that you are in a case where the expert was not totally honest or ethical, you can bring it up with the board and they can get censored. The last thing I want to touch on is, of course, the stress of this. There's plenty of studies that show that MDs are high risk for suicide compared to the average population. And one of the reasons is definitely sort of the risk and the thought process of being sued and losing your money, losing your practice, losing your reputation. There's a website that I found by a psychiatrist named Sarah Charles MD. She also wrote numerous books on this topic that kind of talks about the stressors, because this is not only going to affect you, but it'll affect your family and relationships. Especially cases will drag on. Things won't be dealt with within 6 months. Things will take years, several years. You might be re-sued, you might need appeals. These things will take a while and just sort of eats away at you. So definitely, if you find yourself in these positions, seek help, seek guidance. You have families, you have, co-residents in the past, co-workers. Of course, don't talk about your case to somebody. Anybody you talk about your case in detail with is at risk of also being deposed by counsel. And so just be careful with that. But if you're feeling sort of the stressors from this and you feel down, definitely seek help. And that's pretty much the gist of my senior lecture. Questions? Questions and comments by Dr. G?
That was great.
He said great and important lecture.
Everybody is going to get named. And for me, the time that I've gotten named really it brings out a lot of stress. And I got named in only one case since I've been here 15 years, but I got named in a case where I thought I did everything right, actually, and then what had happened, we got sent home the day before and then came back, so everybody got named. They particularly named me, even though I started the day came back and not doing well. And one advantage I did find of working in a place like this is they go after the deep pockets. So often that if you have good lawyers with you, they can negotiate so that they don't keep your name, but they keep the name of the institution you work for. And therefore, when they ask you if you were named in a lawsuit, your name is not on it, even though you were called and you had to defend it. But they named your institution. This is what happened to me here. I asked them, do I have to report this, that I was named? And they said, no, they named SUNY Downstate. They didn't name you. Yeah. You're just a witness for us, even though I had to come in and give testimony and stuff. But it is, even then, when I knew I wasn't, and my name had never gone up below me, it still is very, very stressful. It really is very stressful.
Yeah.
And I just got to one quick one.
Sure, absolutely. This is why this slide is for you, Dr. G.
So I had left Lincoln to go work in the Philippines for 2 years. I had been at the time the director of the ED when I left. And I had written a whole bunch of protocols and guidelines and all that stuff. And somehow they had a mole in the record room that the lawyers were paying off to look for cases at Lincoln. And somehow they got the information that I was still the director of the ED, although I wasn't. When this case occurred, I happened to be in the Philippines. But they got my hand on a protocol that I had written before I left. And I come in, I'm back from the US, hadn't been there for quite a while. And by my garage in the Bronx, there was this lawyer waiting for me. They named me on a case when I wasn't even in the country and had nothing to do with it. So they'll do stuff like that. I remember he was hiding by the bushes in my apartment, right outside my apartment. It could be very, very stressful.
Yeah, absolutely. And again, it's not about good medicine. It's about strategy. Right? You could do everything right, still get sued, and still lose, just based on set up the strategy. Robbie? Actually, wait. Questions or comments for everybody else? Robbie?
So inspired by Robbie.
Go ahead.
Using a consultant, do you think using a consultant protects you? Also, for example, let's say you get neuro involved for a nerve stroke, whatever, but they sue you. Does that protect that?
I mean, you will get sued regardless, right?
Yeah.
So it doesn't matter. You when you talk to the risk management, to your counsel, they can sort of appeal for your name to be dropped if against the opposition sort of team. But that process has to fully play out. You won't necessarily be dropped right away. And again, you can still be named in an ongoing process for years before your name will be dropped, if you are eventually dropped.
We discussed this in the Tessa's. She looked at some more to the.
Yeah.
Well, also you have to remember 99% don't go to trial.
Yeah. Absolutely.
When you sign your contract with malpractice, like if you work at one of these hospitals, when you sign, the hospital, the insurance company decides whether it's going to go to trial.
Mm-hmm.
And if you give up that right, then you have to pay the expenses for the trial.
Yeah.
So it's the malpractice insurance company that decides whether it's going to go to trial or not. I mean, they have the lawyers, and 99% in Brooklyn, almost nothing goes to trial because everyone loses in Brooklyn.
Yeah.
Because that's the kind of vibe in Brooklyn and even in New York City. So the insurance company, whether you did anything wrong or not, the insurance company will settle, and your name will be taken off. But that doesn't mean that you did anything wrong. It's not a judgment against you. It's that the judgment is the insurance company would gladly give up $100,000 or $200,000 instead of taking a chance of losing $10 million in court. So, if you do get sued, or when you do get sued, and the insurance company says, we're just going to settle, and you decide, well, I did everything right, I don't want you to settle, the economic cost for you will be staggered. Because the insurance company will say, okay, we'll just drop you from insurance, and you can go to court and pay for the court, and then pay for the $10 million suit against you personally. So just because the insurance company says we're going to settle, you should say, well, that's okay. Okay.
Why would somebody argue with that and want to go to?
Because they feel I've done everything right. Why
Even if
should
their
I?
name is going to be removed.
What?
You said their name would be removed.
But even if your name is not removed, then you should still settle, because that the economic cost is tremendous. And most lawsuits, the insurance company will almost never go to court because of the large settlement cost. Also, I work as an expert witness defending doctors. Occasionally, I work on both sides. And the first thing I always do when I'm in a case is subpoena the CV of the other expert witness, because the majority of the expert witnesses on the other side are retired, like ENT surgeons who, dress, and you should see when they go to court. I've done this a few times. They go to court and they have this, beautiful white coat, very expensive suit, and they have the right British accent, and that's how they get hired. And they say whatever the attorney wants them to say. And I always subpoena the CV of the expert on the other side, saying, you are some retired ENT surgeon, 25 years out of practice, and you're talking about, pediatric meningitis.
Yeah.
Like, what do you know?
Your expert witness might not be an ER doctor. It might be like a hematologist or somebody random.
It's whatever they can hire.
Yeah, it's very,
And you could make fabulous amounts of money as an expert.
Oh, yeah.
Fabulous amounts of money. And you can see why retired doctors do that. Like when I have to remodel the kitchen.
That's why there's, that's why certain boards and certain have guidelines of like who can be and what can be an expert witness. And you can always bring that up to actual, like in your case, younger lawyer, bring up like, are you aware of the ethical guidelines of ASAP for expert witnesses to make sure that you are board certified and everything.
You did know about Peter Rosen, the whole controversy guy. So Peter Rosen, the guy who wrote the book.
Yeah.
He testified as an expert witness in, I believe it was Georgia, where now they had reformed and it's now you have gross negligence.
Yeah. Yep.
There's a case of a PE that was missing a kid, and Rosen testified that this kid had S1Q3, and that this PE was actually gross negligence. And his testimony was something along the lines of, I've seen like hundreds of PEs, and every time there's S1Q3, PE all the time, something ridiculous. So then the ER doctor that he testified against lost. As a result of this, ASAP censored Peter Rosen and essentially, said that he was blocking him the whole day.
Yeah.
So he was kind of kicked out of ASAP from that.
Yeah.
So that's the thing. Even in a state with gross negligence, when you have expert
quote unquote
testifying, that, obviously that's not going to change people's sense of medicine. These kind of things still happen.
I urge everybody to, listen to that podcast before you ever get named in a suit. Just it's a very informative podcast. And again, let's finish off the senior lecture with some obligatory sentimental photos. Class of 2020, we were always told, Silverberg and Foley were saying their class is the best. So let's move on. Couldn't have done this without myself. I think that was the most important part of my finishing this residency. As we can tell by the proof, it was always just me and nobody else. Nobody else helped out. Maybe Belknap one day, but nobody else really helped me out. Especially, I don't understand why this is all blurry. This is how the photo came out naturally. But shout out to all of the class, to all of our, my co-residents, a lot of them, especially that became fathers and mothers. To the right corner is my son Breville that I son every day. Otherwise, you have Favi and Henry and Winnie, and then these people over here, especially this gentleman. I think this is Tahir next to Roseman. This is the picture I found of him. And D'Souza's also in there, but I think that's also Ritvik. I'm not entirely sure. And then the only picture of Beth I can find is her doing this to Belknap. And of course, we need the Wu-Tang Clan member Big D to have our own picture by herself. That's important. Lastly, I did one extra shift more than everybody in our class. And so I just want to put a picture of people that owe me shifts. Recently, my goal for residency when I first started was to finish residency and to take care of patients. And an intern or some junior figured me out and put this remark last week that Mo just doesn't have just enough to complete residency and take care of patients. So I thank you for that. It's exactly what my goal was to finish residency and take care of patients. I'll leave it with this, and I'm done.